shall we move on to the next patient for today? And the next patient will be a debate session, Areas of Disagreement. And this session is sponsored by the Unrestricted Academic Grant from USP Private Limited. May I please request the chairpersons to join and take over the responsibility for the session? May I please request Dr. Shantanu Boho, Dr. N.K. Das, Dr. Dhiman Kahali, Dr. Monoranjan Motor, Dr. Dipankar Mukhopadhyay, Dr. Debobroto Roy, Dr. Joyanto Saha, Dr. Neil Bordolu, and Dr. Shahbaz Qureshi to join the session as the chairperson. May I
Dr.
please
Guha is
request
present. Is Dr. Guha present? Dr. Shantanu Guha?
I'm not able to see, sir.
Okay, then let us start without wasting much time. It's a good evening, everyone. Thanks to the organizing team and the scientific committee for giving us the chance to take part in this very important meeting of the CSI West Bengal branch. And actually speaking, the program has been fantastic so far, my knowledge goes. Now, without wasting much time, let us start the debating on a very, very important topic, that is on diagnosis of the endocarditis etiology, and the differential points will be between the echocardiography as well as the PET. Is very, very interesting topic because we don't know much about the PET, though it is picking up lately facial. But definitely PET is also not immune from this kind of information lab. And let us speak us straight away. There are two speakers. One is Dr. Manish Bansal and the other is Dr. Rakesh Gupta. And who is in favor? Dr. Manish Bansal is in favor. Over to Dr. Manish Bansal, please.
Dr. Aniruddh wants to make an announcement. He is muted.
Actually, Dr. Das, there is a last-minute change because this topics was supposed to keep by our senior cardiologist, Dr. Rakesh Gupta, but he somehow got ill, and I requested for one-day notice to Dr. Manish Bansal to take over these topics, and he gracefully agreed that, and I'm indebted to him. And so the informed it will be done by the Dr. Manish Bansal, and against is Dr. Punit Sharma.
So, thank you, sir, Dr. Das, for the introduction, and Dr. Day for giving me this opportunity. So, according to me, echo is the best modality for detecting cardioembolic source in infective endocarditis, and I'll give my reasons here. So this slide summarizes diagnostic accuracy that has been reported for infective endocarditis in the two latest guidelines related to this subject. One is ACC/AHA 2020 guideline, and the second is European Society of Cardiology guideline of 2015. In both these guidelines, the numbers quoted are that the sensitivity of TEE for native valve endocarditis is 90 to 100%, and for prosthetic valve endocarditis, it is close to 90%, and specificity for both is roughly 90%. So these numbers indicate very high diagnostic accuracy. Now, all of us would agree that there is no debate about accuracy of TE for native valve endocarditis. Although for prosthetic valve endocarditis, there may be some concerns and some controversies because there are other studies which have not shown such high diagnostic accuracy for echo. Now, this is one such study published only a few months back in JACC. This is a large study from 3 centers in France, and the main objective of this study was to look at diagnostic accuracy of PET in prosthetic valve endocarditis. So 115 patients with suspected PVE were included, and it was found that echo had a sensitivity and specificity around 65%, and the same for PET were roughly 75%, so slightly higher with PET. Now, there are other studies also which have looked at this aspect, and a meta-analysis of such studies has shown that PET scan has a sensitivity of around 80% for diagnosing prostatic valve endocarditis, and specificity is around 73%. For endocarditis related to cardiac implantable electronic devices, the diagnostic accuracy of PET scan is even better. So for these reasons, the latest guidelines by the European Society of Cardiology have included PET scan as one of the diagnostic modalities in the evaluation of endocarditis. But the good part with PET scan ends actually here. All these good data only make it a complementary tool to echo. There is just no question of PET scan substituting echo. So even if we look at the latest ESC criteria, the diagnosis should begin with clinical features, blood investigation, and echo. They form the cornerstone. If we are able to confirm the diagnosis or reject the diagnosis of IE, no further imaging is needed. If it is possible IE, only then further imaging is needed. And even then, if it is native valve endocarditis, there is no role for PET scan. PET scan is indicated only for prostatic valve endocarditis. And even there are many challenges, which I'm going to discuss in the next few slides. So first, as I already mentioned, PET has no role for native valve endocarditis because it has poor diagnostic accuracy for this purpose. Even for prostatic valve endocarditis, there are many concerns. The most important is very high rate of false positives, because of which specificity of PET is always suboptimal. We need to be very, very careful about the patient preparation, especially diet. And if this is not done properly, then we will not get good results because there will be significant myocardial uptake of FDG. If the patient has undergone cardiac surgery during the last 3 months, PET scan cannot be done. And then there are many other conditions which cause FDG uptake on PET, resulting in false positive test. On the other hand, if the patient has received antibiotics for a few days, PET may be falsely negative because there is no adequate inflammation there. Then there are challenges related to reproducibility also, which I'm going to show in the next slide. And finally, there are issues related to feasibility of PET because of patient being sick, cannot be moved to the PET lab, and cost and all the other challenges. So I go back to the same study which I just showed from France. Now in this study, finally 115 patients were included, but 175 were initially screened. And out of 175, 60 patients were excluded because of one reason or other, which means 40% patients were not suitable for PET at all in the beginning itself. When we talk of echo, it never happens. There is no patient in whom we cannot do echo for diagnosing infective endocarditis. And then these PET scan results were reviewed by two readers. Now, when the same reader was asked to look at the PET images again, he or she was not able to make out whether the PET images were readable or not in many cases. So just for readability, agreement between the same observers 0.61, which is quite modest. And when we look at inter-observer agreement for the major PET criteria, that is valvular uptake, it was again suboptimal, which means that the two readers were not able to agree with each other in many cases. So this is a big problem. But biggest problem as far as PET is concerned is this, that when we do PET scan, we get a good image. It shows us the diagnosis. We can make out that there is para-aortic inflammation. But what next? We cannot treat the patient just based on this image. This PET scan is incomplete without echo. On the other hand, if we do echo and we get this kind of picture, we don't need PET scan. In fact, we don't need any other imaging modality. Echo alone will give us everything that is required for managing this patient. And there are many other cases like this. So this is a patient who presented with stroke. As we can make out, there are vegetations on both aortic and mitral valve leaflets. Mitral leaflet is flail also. This patient needs DVR, This is something which we could not have been able to pick up on PET scan. Only echo can show this. Then this is a patient who had inferior wall MI in October 2019, underwent PTCA stent to RCA. Then 4 months later, he developed mitral valve endocarditis with multiple embolic CVAs. He was treated for that. Blood culture grew pseudomonas. So he received appropriate antibiotics and improved. Now, once he improved, if we do PET scan, the story would be over. But when we look at echo, we found this. There was AML perforation with torrential MR through this. And now this patient needs mitral valve surgery, something which we would have missed if we had looked only at PET scan. Now, this is a patient who's got bilateral PHV in mitral position. We can clearly see a large strand attached to the PHV ring, which confirms the diagnosis of IE. We don't need PET scan after that. Another patient, this patient also presented with stroke and fever. Here we can again see a small strand attached to the ring. It's much smaller than the previous one. Echo can show this. PET scan may not be able to pick this up. Now, para-aortic abscess is a condition in which PET scan is considered to be very good, but even there, echo provides a lot of incremental value. So both these examples are of para-aortic abscess, but the first one shows very limited abscess and the second one shows extensive tissue destruction. So the management of these two conditions is going to be totally different, and this information we can derive only from echo. This is another patient, post-renal transplant, presented with fever. Just the basic transthoracic echo showed this: vegetation on aortic valve, flail, aortic leaflet, severe AR. We don't need any further imaging for confirming the diagnosis or for treating this patient. Now, for patients who have endocarditis related to implantable electronic devices, PET scan is considered to be good. But again, PET scan is not needed in most of the patients because echo alone will be able to diagnose this. Here we have transthoracic echo showing vegetation on the lead, and in this case, it is TE image. Combine these two, more than 85-90% cases, we can diagnose this. Only for pocket infection, PET scan scores over echo because pocket is something which we cannot see on echo.
Dr.
So just to summarize,
go to the summary slide. Yeah.
Last slide. So cardiac PET scan is good for IE related to PHVs and implantable electronic devices, but it is poor for native valve endocarditis. It has many challenges even for PHV endocarditis. And most importantly, it is incomplete without echo, and therefore echo is the best. Thank you.
Dr. Please.
Now in this debate session for detection of cardioembolic sources for infective endocarditis, which is the best, Dr. Punit Sharma from Kolkata will say for PET, that is positron emission tomography. Well, PET is the best. He is talking. And he will defend for PET.
Hi, hello everyone. I hope you can hear me.
Yes.
Okay. So I'm not really going to defend that PET is the best, but yes, I will say that in certain situations, PET will be more useful or have important supplementary roles in the setting of endocarditis. But what I will do is a brief overview of PET-CT, cardiac PET, so that it gives a perspective to our audience. So in PET-CT, you get both the functional and anatomical information, and therefore issues associated with anatomy, such as metallic prosthetic valve or leads, which causes artifacts, those issues can be taken care of. The tracer, most important in the setting of infective endocarditis, is the fluorodeoxyglucose, which is a radiolabeled glucose analog, which is taken up by inflammatory cells in infective endocarditis and other infection, and hence the role of PGPET. The preparation of patients for infective endocarditis is a bit different from the patient for viability assessment, where we do glucose loading and insulin, while in case of infective endocarditis and sarcoid, we do a prolonged fasting, fat-rich, carbohydrate-restricted diet, and heparin for patient preparation. So this preparation is a bit strict, and of course, has to be followed strictly, otherwise the image quality suffers. Before we go, we need to remember that infective endocarditis is a multi-system disease. While it involves the valves predominantly, whether native or prosthetic, it also involves in extracardiac sites, which includes the source of infection from where there is implantation into the heart, and also embolic complication, which could be more symptomatic and more severe than the infective endocarditis itself. So we need to remember that. The specific roles of FDG PET is to provide a confirmatory or supplementary information when transthoracic echocardiography or CT findings are inconclusive. It has been seen that infective endocarditis can be detected earlier with FDG PET, but data is still limited. This is more true for complicated endocarditis, because complicated infective endocarditis can be picked much earlier with FDG PET as compared to TE or CTA, especially in the setting of prostatic valve endocarditis. Also, of course, since echo is predominantly limited to heart and those areas, so to detect a source of infection or embolus to different part of the body, that can only be done with FDG PET. And in another important is you can guide clinical management, whether the antibiotic treatment the patient received is optimum or not, whether it is enough or not, that can be detected with FDG PET. Of course, for native valve endocarditis, the utility is limited, but it should be remembered that in cases of inconclusive or indeterminate finding on echo or other imaging, uptake of FDG in native valve is a major criteria, the major do criteria, and improved its sensitivity of do criteria for detection of infective endocarditis. So this is the group, the possible infective endocarditis group, where FDG PET is most useful. For prostatic valve endocarditis, the sensitivity and specificity is quite high, and when we add FDG PET findings to do criteria, the sensitivity increases from 52 to 70% to about 91 to 97% without compromising the specificity. So this is very important. For cardiac devices, PET usually outperforms echo, not for all kind of cardiac devices, but for some, especially for detection of, say, a pocket infection or area which is beyond the scope of a cardiac echo. You can detect the site of infection, whether it is superficial or deep pocket infection, whether it is the lead infection, which part of the assisted device it is infection, and so on. And it can also help you in deciding upon, in indeterminate cases, the definitive cases, of course not, but in indeterminate cases, whether you can just do with observation and antibiotic therapy rather than going for extraction of the disease. PET can also help in deciding that. And of course, for extracardiac involvement, since it's a whole body imaging, so you can detect either the source of infection or also septic embolus in different parts, which many a time need addressing. Just antibiotic therapy of a splenic abscess or some muscle abscess won't be enough and might need a surgical debridement or not. And of course, since echo doesn't cover these areas, for extracardiac involvement, PET usually performs quite well. I will just quote a paper in this infective endocarditis, both native valve and prostatic with a mixed population, and it was seen that in around 75% of the patient, you can detect additional sites of infection, which could be either a primary site or septic embolus. And it was seen if you had a PET-directed intervention, then there was a twofold reduction in chance of a relapse endocarditis. Just some images. This is a patient, of course, in this patient, as Dr. Bansal mentioned, it was a native valve endocarditis. The PET was negative for the native valve. There was no significant uptake. However, we were able to detect a septic splenic embolism and a pulmonary embolism, septic pulmonary embolism in this patient. This image has been borrowed from the literature for cardiac devices. So in the first image, we can see a pacemaker deep pocket infection, which was detected with pace. Then another one, a prostatic valve endocarditis, which was an indeterminate finding with transesophageal echo. And another patient with the LAD outflow cannula infection with an assisted device. So in this setting, the cardiac device setting, I think PET tend to perform equivalent in most cases, and in some, especially in the assisted device or a pocket infection, much better than echo. PET can also be used for assessment of response to antibiotic treatment, especially if you are giving antifungal, which are toxic and need long-term therapy. There you can whether to stop it or not. You can also take the help of PET CT, and you can be used for assessment of response. Of course, PET has some limitation, which Dr. Bansal already mentioned, that sometimes it could be non-specific. In the post-surgery setting, yes, it was previously suggested that you cannot do PET before 3 months because the healing uptakes will kind of overshadow any infection. But frankly, with new studies come in and with our day-to-day practice, it is usually not much of an problem, especially if you were doing it after 4 weeks of surgery. Then with reasonable accuracy we can detect infection. And of course, if the preparation is suboptimal, because it needs a specific preparation, so and availability and cost are of course issues associated with PET CT. Coming to guidelines, as Dr. Bansal already mentioned, the AHA guideline as of yet does not recommend routine use of PET CT because there are not many prospective randomized study. However, the European Society of Cardiology, it advises the use of PET, especially when the TE findings are indeterminate and it is a possible infective endocarditis based on due criteria, and you want to, or if you want suspecting or want to visualize peripheral emboli or metastatic infective events, in that setting the ESC advises for PET. But of course AHA wants much more evidence as of now. So to conclude, FDG PET is not a replacement but a supplementary tool to echocardiography. It is especially useful in the setting of prostatic valve endocarditis and cardiac device infection. And of course, for extra cardiac diseases, PET CT scores over echo because echo is usually not covering those areas. Thank you and be safe.
Thank you, Dr. Sharma, for your nice deliberation against echo and role of PET in infective endocarditis. There is no scope of discussion in this topic. Should we proceed to the next debate? Chairman, sir.
Yes, sir. Yes, sir.
So let us proceed to the next debate.
Dr. Debabrata Rai is here. Dr. Debabrata Rai. Dr. Deepankar Mukherjee.
Dr. Debabrata Rai, start the next debate.
Yeah. So we will move on to the next debate, that on left ventricular assessment, whether the multi-modality imaging scores over echo. And we have two very erudite speakers for and against the motion. So first, for the motion, I invite Dr. Subhajit Das, a very young, energetic imaging consultant from RN Tagore, to speak for the topic. Dr. Subhajit Das, please.
Subhajit, unmute yourself.
Yeah, I have done that.
Yeah.
Am I audible?
Yeah, you're audible and your slides are visible.
You are audible. Subhajit, please start your deliberation.
Oh, okay. Very good afternoon to one and all present here. I'll be speaking on LV assessment, multimodality imaging, and I'll be stressing on the CMR part. So basically, to begin with, if you speak of CMR, it can either be LV functional analysis or an morphology of the LV. So the functional analysis, as we know that the CMR is now the gold standard for LV volumes, the LV ejection fractions, stroke volumes, end-diastolic volumes, and so on. And speaking of the regional functional abnormality, we can speak of regional wall motion abnormality as in cases of ischemic or a dysynchrony assessment in cases of dilated cardiomyopathy. But I won't be stressing on all those issues because I know that echocardiography is very well and capable of analyzing all these things. Now, moving on to the LV myocardial assessment. So basically, there is a wide spectrum of the myocardial diseases which are very well picked up by CMR, including the ischemic cardiomyopathy, the non-ischemic cardiomyopathy, the myocarditis, a very wide range of the myocarditis, the infiltrative, the restrictive cardiomyopathy, and so on. Now, in ischemic cardiomyopathy, the pattern of the patients that ends up in our departments are usually the chronic patients who present with a stable angina or LV dysfunction. So basically, what we see in those patients are LV wall, variable amount of LV wall thinning, and also regional one-dimensional abnormalities. But what is striking is in the delayed enhancement, we see variable amount of the subendocardial to transmural infarction in these patients, and which has also a lot to do with the viability assessment of these patients. Suppose in these patients, we see the LV wall thinning along with subendocardial enhancement in the septum and the anterior wall, also appreciated in the four-chamber views, and so on. The other important aspect of the CMR is assessment of the complications of myocardial infarctions, starting from wall rupture to the thrombus. As we can see in this patient, there is an LV apical aneurysm with a layered thrombus in the LV apex. As in these patients, there is a LV anterior wall aneurysm in an elderly territory. And also in these patients, there is an inferior wall infarction with a linear hypointense microvascular obstruction. So all these features are very well depicted in CMR, and that's why CMR should be advised in these patients. Now, coming to the non-ischemic cardiomyopathies, the cardiomyopathies that we deal in a day-to-day basis are basically hypertrophic, the restrictive, or the dilated cardiomyopathy. So basically, all these are echo diagnosis. The patient comes with an original echocardiography assessment, already diagnosed cases of HCM. One second. Can I just
I think Subhajit is having some connection problem.
1 second.
Yeah.
Yeah. Can you? Yeah. Can you see me?
It's okay. It's okay.
Yeah.
Yeah, it's okay. Subhajit, please carry on. It's okay.
Yeah. So this is a case of asymmetrical septal HCM. So as we see, go through the video, you can see diffuse LV hypertrophy and also LV apical, LVO2 flow acceleration and SAM, variable amount of SAM and LVO2 obstruction in these patients. But this is something which also the echo will tell us. So what extra we can acquire from an CMR is this variable amount of septal and the anterior wall myocardial fibrosis in the areas of septal hypertrophy. So once we see this, we already know that this is a predictor of adverse outcome in this patient. The patient might need some intervention in the form of ICD and all. So this is something which the CMR will tell you extra apart from the echo. Now moving on to this other patient, which is a case of apical HCM. So a lot of these patients will actually come with a ECG diagnosis of suspected apical HCM, but when this echo will be surprisingly normal in these patients. So once we do a CMR, we'll see that variable amount of LV apical hypertrophy in this patient, and the rest of the LV walls are normal. Again, in this patient also, we can see a variable amount of LV apical hypertrophy. Adding to that is the variable amount of LV apical fibrosis. So this is something which we'll look up to in every patient with HCM. Now again, DCM. So DCM is again a very clear-cut diagnosis in echo, but still I tell my cardiologist friends that they should be sending the DCM patients over to the CMR. The reason is that around 5 to 10% of these DCM patients, they go to have a min myocardial fibrosis, which again a poor prognostic sign. In these patients of primary DCM, the functional abnormalities also are better seen in DCM. And to rule out other causes of dilated heart. So a lot of these DCM patients will go on to have secondary ischemic cardiomyopathy, secondary cases of sarcoidosis, and all these things. So once we do a CMR, the picture becomes much clear. So again, this is a video showing the DCM. You can see a dilated heart with a severe tear, some apical thrombus sitting in the apex. And these are two different patients of DCM, but these are post-GAD images. So one doesn't show any fibrosis, the other one shows linear myocardial fibrosis. So these two are also very similar picture on echocardiography, but they are totally different on MR. So HCM, I'll just, amyloidosis, I'll just brief you. So amyloidosis, the CMR pictures are very characteristic. You can see diffuse subendocardial enhancement in the LV, also enhancement of the atrial wall and the atrial septum. So once we see this kind of pictures, we need not even suggest a biopsy. These are very specific for amyloidosis. Now, sarcoidosis, again, the initial plain MRI will be very similar to a DCM. So once, if you stop in an echo, we'll not be able to diagnose this patient. So once we do a delayed GAT, we can see variable amount of mid-myocardial, epicardial, and transmural enhancement in these patients. So again, this is one patient which has a very normal echo, but due to some conduction abnormalities, they are sent over to CMR, and we can see a scar in the septum. So many a times it is very difficult to point out to a diagnosis. So what is leading to the scar? But the point that if you see the scar, it's important that what it can do to the patient. So these are very normal appearances on echo, and probably very different on CMR. So again, myocarditis, I think myocardial edema is very well picked up, and now with the new T2 mapping and all, very subtle amount of myocardial edema are picked up. Again, this myocardial edema leading to the fibrosis in chronic patients. Now, tubercular myocarditis, they present as a dilated cardiomyopathy, but once we do a CMR, we can see diffuse epicardial enhancement in the LV and also in the RV wall. So this will present typically as a DCM in echo. Now, Takusabu, again, it's a relatively easy diagnosis for us, regional apical ballooning on MR, but the characteristic thing that makes it different from a echo diagnosis is that there is no enhancement in the apex. Enhancement in the apex points out to some other diagnosis like an apical infarct, and it is totally reversible. The summary is that cardiac MR is not here to replace or anything. It is just an additional imaging diagnostic modality, and it has also become the gold standard for assessment of the myocardial function. It adds a diagnostic value to every patient with LV dysfunction. It is excellent in classifying the cardiomyopathies, including the ischemic or the non-ischemic ones, and that's why it makes us indispensable for assessment of the left ventricle. Thank you very much. Have a good day.
Thank you, Subhajit. May I now call upon Dr. Manish Bansal to speak against? Dr. Manish Bansal, please.
So, as I was saying, Dr. Das mentioned that cardiac MRI is the gold standard for assessment of LV function, and it is the only non-invasive modality for myocardial tissue characterization. And for these reasons, CMR is definitely used quite often in the management of the patients, especially those who present with myocardial disease. But my submission is that despite these advantages, most of the patients will not need MRI for, it's not moving. Okay. Most of the patients will not need CMRI for their evaluation and management. And I'll begin with LV function because there is repeated emphasis on this fact that cardiac MRI is the gold standard for LV function assessment. Now look at this patient. This patient has got severe LV systolic dysfunction. Now, whether this EF is 22%, 25%, or 27%, it is not going to make any difference to the patient's management. So we don't need MRI here. Similarly, in this patient, we can make out that there is localized wall motion abnormality. EF is around 45%. Again, no further imaging is needed for assessment of LV function because management is not going to change. Who are the patients in whom accurate LV-EF estimation might matter? These are some of the examples. Patients with HFrEF in whom we have to start heart failure drugs. So there the cutoff is 40%. Then CRT, AICD, AVR in patients with ASAR, mitral valve surgery and mitral regurgitation. So these are the conditions in which we use certain LV-EF thresholds for decision making, and there it might appear that accurate EF estimation is required. But is it really so? And that is what I'll go through in the next few slides. So just first, let us look at use of heart failure drugs in HFrEF. Now, guidelines recommend that the patients who have EF less than 40%, they should be treated with beta blocker, RAS inhibitor, including MRA, and now SGLT2 inhibitors. But the whole concept of using 40% for defining HFrEF is now come under great controversy, and there's a lot of data to show that this concept itself is basically flawed. The earliest study, SOLVE study, used that cutoff, and since then that cutoff has remained stuck with this diagnosis without any justification. If we look at the studies which have included patients more than 40% of EF, so-called HFpEF or heart failure with mid-range ejection fraction, then we consistently find that the patients who were having EF between 40 to 55% benefited with heart failure reduction drugs. And therefore, if I have a patient whose EF appears to be around 40%, then I would definitely put that patient on these drugs rather than going for MRI to confirm whether it is 38% or 42%. Coming to CRT, CRT is indicated in patients with EF less than 35%, LVV, and intractable heart failure. But there is also a lot of data now to show that even if EF is 35 to 40%, but the patient has LVV, broad QRS, and is having worsening heart failure, CRT benefits. So again, there's no reason to be very rigid about EF here. For ICD, we need to be more strict. So there, although the cutoff is 35%, I would be more inclined to go towards 30% to make sure an ischemic heart disease for ICD recommendations. So again, accurate estimation of EF by MRI may not be needed here. And another very important point, if you look at all the trials from which all this data has come and the guidelines have come, whether it is SOLVE, CHARM, and so many other trials for drugs and so many trials for devices, we need to remember that all these trials used echo for estimation of EF and echo for patient selection. So after having done these trials and deriving data from these trials, changing the goal post and using MRI for estimation of EF does not make sense. If we really want to be very sure regarding EF, we have other echo modalities also like 3D, and now we have strain imaging also. We all know that global longitudinal strain is highly reproducible and excellent prognostic marker. Its excellent prognostic value has been demonstrated in a number of clinical conditions. This is one study published very recently, 60 patients with breast cancer undergoing treatment. The authors looked at variability of echo and MR, and they looked the maximum variability, which was a combination of inter-observer variability plus test-retest. So that is the maximum variability that can arise in estimation. Now look at LVEF. We find that variability for 3D is same as that of MRI, which means if we are using 3D, we don't need to use CMR for this purpose. And if we look at GLS had much less variability. And therefore, nowadays, for serial assessment of LV systolic function, GLS is considered to be far superior to EF estimation. This is one example, a patient with cancer undergoing treatment. This is baseline. EF is 61% here. GLS is normal. Patient is put on trastuzumab. 3 months later, EF is same, but GLS is significantly reduced. Now, this patient needs treatment. This is what has been shown by a very recent multicentric study, SUKUR study, which showed that when we treat patients according to GLS, we end up with better LVEF. If we treat patients according to EF, the outcome is not that good. Therefore, we should move away from EF and embrace GLS for this. Now, coming to valvular heart disease, there's again a lot of data which is showing that GLS is a much better parameter to predict to pick up early LV systolic dysfunction and for decision making in valvular heart disease. This is one meta-analysis in patients with aortic stenosis. All patients were asymptomatic, had EF above 50%. So these are the patients who don't need AVR. But in them, when we look at GLS, we find that the moment GLS was less than 15%, there was significant increase in mortality over 2 years and 4 years. And these were not uncommon. 1/3 of all patients had GLS in this category. So leaving them without surgery is probably unfair. And we have similar data for other valvular heart disease conditions also. Now, a reason why GLS does so well is that it correlates very well with myocardial fibrosis, and it has been shown with histopathological studies also and with CMR. And therefore, GLS can do many of the jobs which Dr. Das mentioned about myocardial diseases, although I agree that there is no comparison between echo and MRI as far as myocardial assessment is concerned. But again, it's not required for every patient. Here I have a classical example of amyloidosis. After looking at these echo images, we don't need MRI for anything. And even for HOCM, it is right that LG detected by CMR is a good predictor of SCD risk, but that is needed only when we don't have other risk markers. So this patient with this thick interventricular septum, we don't need any CMR for SCD risk assessment. And even for apical hypertrophy, actually we don't need CMR in most of the patients. If we use echo properly, we can use contrast, which will diagnose most of the patients with apical SCM. And if we don't have contrast, we can just look at color Doppler or strain. They are able to pick up apical cardiomyopathy quite reliably. And then finally, I also need to mention that CMR does not come without challenges. Now, when we look at these images, these are short axis slices which are required for estimation of LV function. Now, we need to remember that each slice is acquired separately over 12 to 15 breath holds. So patient has to hold breath 8 times to get this, and then these are combined, and then the radiologist has to track the endocardium at end diastole and end systole to get LV, EF and volume. So accuracy of CMR cannot be taken for granted. There's a lot which goes into that. CMR is not feasible in many patients because of many reasons. The last 10 patients whom I sent for CMR, 4 could not get it done because of these reasons. And then there are issues of availability, extra test and cost. So to summarize, no doubt that cardiac MRI is most accurate for LV volumes and EF estimation. It is only non-invasive modality for myocardial tissue characterization. But I'll again say that it is needed only in a few patients, not in most. Thank you.
Thank you, Dr. Bansal. I think it is quite well understood that echo will suffice in most cases, with cardiac MR acting as necessary supplement in such some special areas like dilated cardiomyopathy, where detection of MMF has brought about a significant change in therapeutic paradigm. And as an imaging naive interventionist, I expected few illuminating comments from both the speakers on viability assessment, especially in the light of emerging concept of dynamic independence response. Anyway, both the speakers have done quite well. And now I pass the mic on to Dr. Dipankar Mukherjee. Sir, the floor is yours now. Thank you.
Yes, thank you for giving this opportunity. And I totally agree with you. I totally agree with you about the comments. And viability is the area where MRI were being used in a larger way. That is true. But strain brain imaging has given a good weapon to us, which is very much useful nowadays. So other than this, I think both the speakers have done well to the topic, and I think we should go to the next topic, which should be cleared by our Dr. Mia Kantidas.
Echo is what I need. That is enough for me. The diagnosis of severity of aortic stenosis is purely Doppler based. We use the aortic annulus area, then we look at the LVOT Doppler VTI, we look at the CW across the aortic wall, take the ejection time, and also take the peak and mean gradient, and we can get stroke volume, we get aortic valve area, we get transvalvular flow rate, and that is a comprehensive evaluation of aortic stenosis. The severity of aortic stenosis, depending upon the gradients and the velocities and the aortic valve area, is purely echo Doppler based. So also the Doppler is very, very versatile. Look at this patient with apical 5 chamber view showing a gradient of 56 by 33, while the right parasternal view is 80 by 48. 20% of the patients have got a higher gradient through right parasternal region. So also we can deduce whether the patient is really truly asymptomatic by using the exercise echo. So in an exercise echo, we can look at the angina, ECG changes, BP changes, ventricular arrhythmias, changes in the E by E prime, increase in the mean gradient, increase in the PA pressure, fall in the ejection fraction, fall in GLS, peak VO2, so and so forth. It is the most versatile test that you can do in an asymptomatic aortic stenosis. One can also do a good myocardial imaging by using a contrast echo for the ejection fraction, using speckle tracking echo for the GLS, and also using tissue Doppler for the E prime and S prime. And with the ejection fraction less than 55%, looking at the LV mass, looking at the GLS by 2D or 3D, looking at the E by E prime, we can deduce whether the myocardium has started developing fibrosis or not. So also the prognostic staging of the aortic stenosis deduced from the partner 2 trial is entirely echo based, and from stage 0 to stage 4 there is a continuous increment in the mortality. So also the hemodynamic classification of aortic stenosis is entirely echo based. So we look whether the flow is more than or less than 35 and the mean gradient is more than or less than 40 mm of Hg, and we get 4 classes of aortic stenosis, and the mortality keeps on increasing from the normal flow low gradient to low flow low gradient. The low flow low gradient can be further classified into classical and paradoxical depending on ejection fraction, and each one of them can be further differentiated into true S or pseudo S, and this is possible only because of echo, Doppler and dobutamine stress echo. So we can differentiate a low flow, low gradient aortic stenosis whether it is true or pseudo by low dose dobutamine. By giving low dose dobutamine, we try to increase the stroke volume up by 20% and the transvalvular flow rate about 200 ml per second, and we check the aortic wall area and gradient at these hemodynamics. Those who do not have this contractile reserve, we can still do a lot of things. Like in this patient, who is a 70-year-old lady with LV dysfunction and a resting mean gradient of 30, we will give the dobutamine from 5, 10, 15, 20 increments, and each time we take the LVOT Doppler and the trans aortic CW Doppler, and we chart it out and see that the aortic wall area has not increased much. So also the transvalvular flow rate hasn't increased much. So this patient doesn't have much of a contractile reserve, but still we can plot the flow rate against the aortic wall area change and then can extrapolate it to 250 ml and find out this is truly severe aortic stenosis. Now, why not use an aortic wall CT calcium score? It is a good test, but you can see that there's a very large range of AU score where you are completely clueless. Plus, these cutoffs are deduced from the Caucasian elderly population. So what about the TAVR planning, CT versus 3D TE? Now, you can use CT with the patients with a normal or near normal EGFR, but when you have an EGFR which is less than 30, you can take a very good 3D data set of the aortic root. From that, you can put the flexi slices in such a way that you go through the center of the LVOT and also cut the long axis at the commissure between the LCC and NCC and through the midpoint of the RCC, and can get a perfect perpendicular a cross section at the LVOT or aortic annulus and can get a perimetry. So also we get a good idea about the sinus of Valsalva, STJ, and the ascending aorta. We can also find the left main coronary artery, and once you get the left main coronary artery, you can put a vertical plane across the left main, and from that you get such beautiful images where you can see the annulus and also the ostium of the left main, and can measure the height of the left main ostium. So also you can find out the ostium of the right coronary artery and also can get the height of the right coronary artery. So in the pre-TAVR imaging, according to the appropriate use criteria of the ACC, 3DT is appropriate for assessment of annular size and shape, and so also for the cusp and degree of calcification, and it is maybe appropriate for the height of coronary measurements and also assessment of aortic dimension. During the procedure of TAVR, echo is the supreme because it looks at the depth of implant, regional wall motion abnormalities, intraprosthetic legs, the PVL estimation, prosthetic gradient, pericardial effusion, and also can guide the septal puncture when it is an anterograde crossing. If we can quickly scan for a paravalvular leak on the table in the cath lab, and then we can know the extent of the paravalvular leak, and we can find out how much circumference the paravalvular leak is. If it is more than 30%, it is severe. So also we can actually planimeter the vena contracta area, and if it is more than 30 mm square, it is a severe paravalvular leak. So if you look at the appropriate use criteria of ACC, 3DT is the supreme most appropriate for the intra-procedure evaluation of TAVR. What about the post-TAVR evaluation? Because there is only echo which will look at the prosthetic mean gradient, whether it changes more than 50% pre-discharge, whether there is a restricted leaflet motion, whether there is a thickening of the leaflet, whether there is a paravalvular leak still present. And if you look at the appropriate use criteria, it is only the transthoracic and transesophageal echo which is advised to be done for the post-TAVR assessment. Thank you.
Dr. Qureshi? Yeah, Mona, please.
Thank you, sir. Can I start?
Yes, please.
Okay. So that was a great talk, Dr. Nitin, and I'll systematically go through everything except that multimodality imaging cannot be within the cath lab, and so intraoperative, we can't help you. But as far as everything else is concerned, well, multimodality imaging is all that I need. So aortic stenosis, we know, is the most frequent valvular heart disease, and it may be either bicuspid, post-inflammatory, or degenerative. And the toolkit for multimodality imaging that we have is CT and MRI. So what we want to do is exactly like for echo, we want to look at aortic stenosis severity, morphological and functional biventricular assessment, characterization, quantification of myocardial involvement, and then plan and guide the TAVR and post-TAVR complications exactly systematically like what Dr. Nitin just went through. So starting with the aortic stenosis severity, there is no doubt that CT enables the reconstruction of the aortic valve in the three orthogonal planes. So we get an excellent view of the aortic valve for assessment of what is its dimensions. For Cine CMR, in case we don't want to do CT, we can also take the patient to CMR, and again, we get excellent valve planimetry. We can have, with MRI, we can not only have the planimetry, but we can also evaluate what exactly is the functional extent of the aortic stenosis. And this can be done on the phase contrast MR, where flow quantification can be done with through plane estimation of the peak velocity and the peak gradient. And this is pretty much like the Doppler, where we're looking either at the Bernoulli equation or we are using physiological valve area calculation by the continuity equation. You also have now the 4D MRI data, which allows computational fluid dynamics. So flow quantification can be done through the aortic stenosis. Going on to morphological and functional biventricular assessment, we know from all our previous speakers also that MR today is considered the gold standard. And if we're looking at echo, while the margin of error is 11.5% for ejection fraction evaluation, CMR has only 3.7%. So definitely CMR is currently considered the best. Going on to characterization, quantification of the myocardial involvement, we do know that continuous remodeling in a pressure overload hypertrophy in aortic stenosis results in a chronic myocardial injury. And this is characterized by interstitial fibrosis and myocyte degeneration. And this can be evaluated on the CMR So we can have on correlation of the histopath and CMR that a worse LV function with larger LV volume, mass, and focal myocardial fibrosis are associated with a much worse prognosis in severe aortic stenosis. The mid-wall fibrosis, in fact, is an independent predictor of mortality in aortic stenosis. So having evaluated the aortic stenosis and the myocardium, we now want to plan and guide intervention. And we do know that TAVR today is almost overwhelming the clinical case for it. And because TAVR is superior to SAVR, so TAVR is here to stay. And the success of intervention depends on accurate deployment of the prosthesis. For accurate deployment, we need to have accurate sizing, and we need to match the prosthesis size to the patient anatomy. And CT today, in its pre-procedural assessment, is the mainstay for patients for workup of TAVR. And what we do is we acquire all the way from the root of the neck to the femorals. As far as the aortic root assessment is concerned, we know that the aortic valve complex is indeed a complex structure and consists of many components from the sinotubular junction down to the annulus. The annulus, the important thing is that it is not circular and it's a virtual ring. So how low do you go? Even if you get on a echo, even if you get the perpendicular plane, how low do you go and what will you call the annulus? With CT, we know that we can reconstruct the annular plane by the double oblique angulation where exactly the valves sort of reach. So when we look at TE and TTE, the problem is that they assume that the annulus is circular. And there is a systematic problem in 2D imaging of an ovoid annulus. So what happens is we have to be very careful when comparing echo and CT measurements, because classically, and this was the reason why initially there was so much paravalvular leak, was because the CT actually shows that it yields a larger valve size compared to TEE, and TEE estimations are typically larger than the TTE. The annulus assessment also shows a certain dynamism of the aortic root, where the annulus is larger in systole and smaller in diastole. So a systolic assessment is preferred to prevent undersizing. Once the annulus is obtained, we get it on a true double orthogonal plane. We then look at all the diameters, the perimeter, and the area, and then we get the derived diameters. The discrepancy in sizing is known to occur, and a valve undersizing can be responsible for the paravalvular leak or for device embolization. The concept of oversizing also exists because oversizing can potentially cause a lethal complication of annular rupture. Aortic valve calcification, as was shown, also exists, and you have to look at valvular level calcifications together with calcification of the landing zone, be it the annulus or the LVOT. And the degree of calcification, the form may actually vary. It may be very bulky, it may be transmural, and then these can complicate both successful prosthesis implantation and can also be predictors and the cause of severe annular and subannular calcification leading to annular rupture. And so we need to be extremely cautious and do not oversize aggressively in an annulus with calcification. Valve morphology can be very well evaluated by CT and could be tricuspid or not. And in the TAVR era, we know the classification of bicuspid valves has varied depending on the tricommissural to bicommissural rapid type, non-rapid type, leaflet morphology, and orientation. So here you can see that it's a rapid type coronary cusp fusion, and other valve morphologies do exist from uni to quadricuspid valves. Coronary ostial height, again, is very well evaluated on CT because we can exactly tell where is the lower end of the coronary ostia. And to prevent ostial occlusion, we want to have the coronary ostial height, the leaflet length, and have an assessment of the calcium because we do not want to end up with ostial occlusion. LVOT assessments are also very important because occasionally you might have hypertrophy or subaortic stenosis. Otherwise, you might have a flared LVOT, which is aneurysmal, and then again, you want to evaluate how it would impact the prosthesis that you're putting. The sinus of Valsalva and sinotubular junctions are very easily evaluated, and these again may be responsible and have implications for post-procedural paravalvular leak. The determination of the best imaging plane is also important because it decreases the number of aortograms, it shortens the procedure time, and saves a large amount of contrast besides giving a coaxial implantation and optimizing that. The ascending aorta can be evaluated by CT very easily, and that again is one of the guidelines for size selection. And then not only are we looking at the aortic root and the ascending aorta, but we also need to have the access root assessment, which echo definitely cannot do. And going there, we can look at, we know that the transfemoral vascular access is the most commonly used access. We want to have the true cross-sectional area to know the vessel diameter. We want to look for tortuosities and the possibility of any high-risk atheromas, dissections, intimal flaps, or severe calcifications, which may be dangerous for the vascular access. So we need to be able to predict any vascular complications that may arise. In the event of an inaccessible transfemoral route, we may have to look at other options like the subclavian or the axillary approach. So the toolkit also wants to now look at post-TAVR complications, and here the complications include paravalvular leak, and the factors responsible for the paravalvular leak are invariably either undersizing, under expansion of the valve, inaccurate valve or prosthesis sizing. It could also be asymmetrically large calcifications, which may preclude a complete prosthesis expansion, or the prosthesis may be too high or too low in implantation. The thrombus, again, is very well evaluated on CT, where you can see this early hypoattenuated leaflet thickening. And not only that, we can also look at leaflet motion abnormalities. The left bundle branch block is another concerning feature, which sometimes leads to low ejection fraction, more pacemaker implants, and the cause is traumatization. And on CT, you can actually evaluate the length of the membranous septum, which is useful. While CT is the modality of choice, not infrequently, MR may be used in special circumstances where you have renal insufficiency, in which case MR also, very similar to CT, can evaluate the aortic stenosis, the annular diameter, the ostial height, the valve morphology, ventricular function, myocardial assessment, together with vascular access. Here you can see that you can have a one single MR angiography of the entire body and know exactly how the vascular access looks. So definitely when we're looking at multidisciplinary heart teams looking at TAVR and aortic stenosis, multimodality imaging is all I need for success of management of these aortic stenosis patients, because it enables morphofunctional assessment of the aortic stenosis severity, the ventricular and myocardial involvement, together with guiding intervention and post-TAVR complications. Needless to say, intra-operative and intra-procedural, you need to have the echo. Thank you so much.
Thank you, Dr. Mona Bhatia, as well as Dr. Nitin Butkule. We don't have much scope to comment right now.
Dr. Das,
yes.
This is Dr. Roy. Can I make a quick comment?
I think you make a comment at the end. There is no scope for comment in between.
Okay.
May I call Dr. Qureshi to call the next debate, call for the next debate and debaters.
Thank you very much. It has been an excellent day with very good presentations, especially in the debate session. Very energetic, very passionate, supporting their modality of imaging. The next debate is on cardiotoxicity assessment and multimodality imaging. They are always required. And the two who are going to speak for it is Dr. Johann Christopher, and the one who is going to negate it is Dr. Satiash Govind. May I now request Dr. Christopher to please make his presentation.
Good evening, everybody, and thank you once again, Dr. Das, for this wonderful opportunity. And today I'm going to talk about multimodality imaging as the very important tool for cardiotoxicity. In comparison, you will see that the 2D echo is the mainstream investigation, but there are certain niche times when you require a multi-tool set like MRI, MUGA, and CT to evaluate these patients. Cancer therapeutic-related cardiac dysfunction, or the new name CTRCD, involves a decrease in EF of greater than 10% to a value below the reference value of EF of 53% as per the latest American European guidelines. And this decrease may be further categorized as symptomatic or asymptomatic, reversible, partially reversible, or completely irreversible. Now, there are multiple actors here, but the most important takeaway is that there is two groups, the adrimycin group and the trastuzumab group, which we'll be looking at. The general mechanism of cardiotoxicity basically involves the relation between the cancer cell and the T cell, and the varying immunity that causes the T cell to cause tissue damage. There are generally an oversimplification, but it is two types of cardiac dysfunction. The first is involving cellular death, biopsy changes, cumulative dose-related changes, and permanent damage, and the model is doxorubicin. And the second type involves cellular dysfunction, no biopsy changes, it's not cumulative and reversible, involving trastuzumab. What is very important is the role of early imaging, and as you can see here, that when you're well within the 6 months, the chance of responding to cardioprotective treatment is very, very high, and after 6 months is almost certainly not. Looking at the ESMO 2 to 20 consensus, you can clearly see here, after you do the baseline check, the most important is the LV ejection fraction, 50, less than 50, and less than 40%, wherein you stop the chemotherapy drugs, but it is in the 40 to 50, which is a gray area, and you need to consider cardioprotective therapy. So you need to have a imaging which is very, very accurate in this area. Also, when you're doing periodic follow-ups, there is a greater than 10% drop in EF, and the ejection fraction baseline should be less than 50, wherein again you stop the therapy and you start cardioprotective therapy. Whereas if the EF decrease is less than 10% and the EF more than 50, then you continue. So EF is a very, very crucial tool for measurement. In the flow chart for cardiotoxicity, also the recommendation is that you do an echocardiography as the first line, either 2D or 3D, 3D being preferred because of the variability, and a GLS as well. But if the acoustic window is poor, then you must, as a second line, move to CMR or MUGA. And also, if the ejection fraction is lower than 50% at baseline, you do an abnormal TROP-T, and then you use a more sensitive method to follow up these patients every 3 months for a year, and then every 1 year for 5 years. So this will really depend on using of the higher equipment like MR and MUGA. Why not MUGA? Why not echo? 1/3 of the segments could not be reproducibly analyzed, and 60% of patients were not able to view the apex. And the inter-observer variability of EF greater than 10% is almost 11%. And obese patients with window issues are considerable in our population now, and also the varied expertise of echo operators. In fact, most corporate hospitals have technicians to do them. If you look at the temporal variability, you can see that in a single day, when you repeat the echo, there is a wide variation of ejection fractions, except in 3D where it is fairly consistent. The sensitivity of the technique is very important. And if you look at the range here of 10%, which is what is there in most of the guidelines, you can clearly see here that echo falls out of it at 11% coefficient. Only MR is within this 10%. So to be able to measure the change of 10% requires a higher technique. So therefore, multimodality is important. Ejection fraction, as you know, is a gold standard in MR. The inter-observer variability is low. It's extremely accurate and also reproducible. And with the new parametric approach with T1 mapping, it is easier to get damage very early. There's no geometric assumptions. It's cost effective, but not cheap, and availability is not an issue anymore. We usually like to look at more than ejection fraction because it's dependent on the loading conditions. There's an inability to visualize all segments on echo, and there's a variability in EF reproducibility. And the deterioration of EF is towards the end of the cardiac dysfunction. So among the various tools, we'll be talking about the MUGA, which is a non-invasive technique using 99 MTC erythrocytes to visualize the gating pool through a gamma camera. It's used to monitor ejection fraction in these patients. It's highly reproducible with the precise quantification of left ventricular volumes in dysynchrony. There are no geometrical assumptions, and there's a large body of data. The only problem is radiation. And this picture clearly shows an ejection fraction and volume, which is normal. But 2 years down the line after doxorubicin, you can see the dilatation very accurately measured. The CT, again, is used in these patients, especially if we want to evaluate pericardial or coronary artery disease. However, the radiation is a problem. And this is a patient post breast cancer therapy. You can see the massive dilatation of the RA, RV, LA, and LV, and the mild pericardial thickening there on CT. PET also can be used in these patients. And you can clearly see here a patient who started the chemotherapy, and then 1 year down the line, you can see there is a significant increase in the FDG uptake in the heart, suggesting that this patient had an adriamycin-induced inflammation of the LV. CMR obviously is the gold standard method in the evaluation of cardiac volumes, mass, and function. And also, cardiac tissue characterization is only performed by CMR. The T1 map is a new tool in our armamentarium and is able to detect very, very early damage much before the EF falls. When we're looking at the type 1, which is irreversible damage, you can clearly see here this patient had a dilated LA and LV. There is scarring of the LV, and the T1 map is abnormal, and the ECV is increased in this patient, suggesting that this patient possibly will not recover. In a patient post-doxorubicin, again, you will see that there is edema in the LV, there is delayed enhancement suggestive of scar, and the T1 map again is abnormal, suggesting poor recovery. Even the CMR scar can be evaluated in detail, and you can see this patient on follow-up shows an increased scar in the same area. MR gives you a composite map. It gives you T1 imaging, which is non-contrast. Very early inflammation can be picked up. It will give you the gadolinium enhancement, and it will also show you the increase in ECV, showing it to be a very, very composite tool. In constrictive pericarditis, again, the MR shows you the hemodynamic abnormality, the abnormal septal motion, the thickening of the pericardium. And if you add CT to this, you will see that there is a shell-like calcium around, suggesting that this patient will need surgical therapy. In type 2 cardiotoxicity, again, CMR tagging shows very, very early regional wall, suggesting damage. And CMR also has strain, where you can see that though the circumferential strain is normal, the peak systolic GLS is abnormal. And if you look at the algorithm, if you have a GLS of more than 15, this patient at 16, it's certified as subclinical LV dysfunction. Well, you can also get it on echo. Most of the walls cannot be seen on echo very properly. This is a patient who started off with a normal myocardium, but 6 months down the line post chemo, you can see that he has increased T2, suggesting that there is inflammation of this patient. The T1 mapping also can be done sequentially, and this does not require contrast. It's only a 10-minute test and can be done in a very cheap manner. And here again, which shows a hardly discernible myocardial delayed enhancement, but the T2 is clearly abnormal, showing a very sensitive early pickup of cardiac dysfunction. Most of these patients with reversible will not have scar, and the pericarditis is usually mild and usually reversible. So the composite CMR utilization is that there are multiple tools that we can use: T1, T2, ECV, late gadolinium enhancement, volume, and ejection fraction. All these tools can be used together and to look at it. So therefore, monitoring cardiotoxicity requires an accurate sequential monitoring of LV function, morphology, and tissue. Ongoing therapy trials have now chosen cardiac MRI as a parameter for the primary efficacy endpoint, and 2 trials ongoing are the Manticore and Prada, which will tell us the true place of cardiac MRI in these patients. To conclude, echo has problems with operator dependence and limited in case of thoracic abnormalities, and the operator also has to be good. The Muga has excellent reproducibility, but the problem with radiation. Cardiac MRI is accurate, reproducible, detects early and diffuse myocardial fibrosis. However, it does suffer from the problems of cost and claustrophobia. In conclusion, the use of CMR and multimodality imaging demonstrate higher sensitivity in detecting early cardiotoxicity. It improves prognosis and quality of life of cancer patients. Thank you.
Very good evening to all of you. Cardio-oncology over the last decade has become a big field in itself. There's a lot of data which is increasing every year. So let us look at how echo versus the other imaging modalities. So I have tweaked the title slightly, so it is not always required. So what do I mean by it? So one is the way we look at the cardiovascular complications. So these are the stages. So we look at risk stratification. There is early detection of injury. There is prediction. And what are we looking at? We are looking at LV dysfunction, pericardial disease, coronary disease, pulmonary hypertension, and the aorta itself. And when you look at this, if you can call this word as the armamentarium. So echo is right at the beginning. So it is the at the front line, and that is the test when it comes to looking at the above conditions. Now, what are the frequent cardiovascular toxicity conditions which we come across? There is LV dysfunction, there is heart failure, and then there is myocarditis, which can manifest in different ways, hypertension and its effects on the heart, myocardial ischemia, thromboembolic events, and then PH, and then valvular heart disease, pericardial disease, and atrial fibrillation. So all these conditions, echo has been doing for a long time and has always been the mainstay and the primary investigation. It's a frontline test. Now let's look at the definition of cardiotoxicity. So this is from the Cardiotox registry. So this is the latest. So what is the main sort of focus on the parameter here? So there are many ways, there are many grades, there are many types. So I will focus on myocardial damage and the dysfunction, and what is defined as toxicity is something which is new or worsening of at least 1 grade after chemotherapy initiation. So that means we are looking at normal LV function and looking at the biomarker. So once it becomes abnormal, so that's when there is some amount of toxicity, and as it worsens, that is how things go wrong. And echo in terms of its EF and systolic volume, GLS, and also left atrial volume, the diastolic parameters also play a small but a crucial role here. Now, the definition itself, if we have to look at the imaging modalities, so one is the subclinical LV dysfunction. So here biomarkers have been tried, troponin, so not very great. Imaging GLS, lot of data, so which has now become the mainstay, which has become a big parameter in terms of looking at the subclinical dysfunction. So asymptomatic LV dysfunction is characterized as LVEF less than 50%. Echo does it. Here there are no features of heart failure. And once they become symptomatic, you have a symptomatic LV dysfunction. So if you look at the two parameters, echo is again in the front line, which does these two parameters. Now let's look at these steps in monitoring. Before therapy, you have risk assessment. During therapy, there is detection. Following therapy, there is monitoring. So here again, if you can look at it, echo is used at every step. So this is again nothing new, but as part of the protocol for cancer monitoring, whether it is before, during, and following therapy. So echo is again used at every step, at every level. Now, what are the levels of monitoring? So we have categorized this as low risk, you have intermediate risk, and high risk. And again, whether it comes to the assessment before, during, and after, or even when categorizing them as low, high, intermediate risk. So again, the echo is at every step. So it is a basic protocol after therapy, whether it is at 3, 6, 12 months. So this is something which should be kept in mind. Now, in terms of the recommendations, so let's look at the various toxicities. So here you have LV dysfunction, myocarditis, and echo comes right on top here, and then 3D echo if somebody has it, and if it is done, that is the best one to look at LV function. GLS again is pretty useful, and then valvular heart disease, echo comes on top, pericardial disease, coronary heart disease, pulmonary hypertension. So echo is sort of featured at every point, at every level, and it's right at the top. And vascular toxicity is the only area where CMR and CT come into play. Then let me have an example here of how we can look at this. So here we have the 40-year-old female, hypertension, hypothyroid, CA breast, planned chemo, and normal echo, so low risk. Now, in terms of what we can identify in this particular patient, so here GLS has been used, and there is 3D LVEF, which is quite accurate when it is used. So these are the two parameters which are recommended and which should be used whenever possible. So here you can see that the EF is around 61%. The GLS is pretty good here. After 3 months, it has gone down after chemotherapy. So at this point, the oncologist decided to withhold, and then this is at 7 months. The EF does show a little improvement, but the GLS continue to be at this level. So at this point, patient is still waiting for the chemo. But the point here is, the message here is that the GLS and EF are pretty accurate, and it is used routinely. Now, if they don't work, for example, if imaging window is not so good, so the inter-observer or the intra-observer variability, this can be sort of neutralized to a large extent by use of contrast. And apart from this, the other chambers are also sort of easily visualized. So looking at left atrium, looking at pulmonary hypertension, the PA pressures, and looking at the LV filling pressure. So this is the big advantage here. Then it can also easily and very accurately and very reliably look at pericardial diseases, look at valvular heart diseases, and any structural changes in terms of remodeling. All these abnormalities can be seen. And if the 3DEF is not available, at the least 2DEF, which is very well validated and recommended also, can be used. Now, in terms of early predictors, you have the sensitivity here. So this is just to look at how the troponin looks in terms of GLS. So very low sensitivity. And when it comes to specificity, again, slightly better, but still very low. And the positive predictive value, all of them don't do well. But when it comes to the negative predictive value, GLS does fairly well. So GLS is fairly well established. Now, the next is looking at the various examples. So this is again enough literature, enough publications are there in terms of the various ways of how we can look at strain and how it can be used for serial monitoring. So very easy, very cheap, and very reliable. Now, what about the utilities between the modalities themselves? So here you have echo, and then you have the rest of the imaging modalities. So these large number of pluses means it is pretty useful. So if you look at echo,
all the way down here. You have a very high utility, very high reliability, except when it comes to myocardial fibrosis. Echo doesn't do well here, and this is where CMR scores. But again, the message here is that echo is very reliable and very well established and validated and recommended. Now, when it comes to practical considerations, radiation exposure, none. And in terms of cost, it is very cheap compared to the other modalities. And also in terms of practical considerations, in terms of availability, it is very easily available, very widely available. So that is not an issue at all. Then comparison between centers, and this is again looking at the modality itself. And this is a study from Europe where they looked at both cardiology clinics as well as no clinics. And again, a very high use of echo here, 82%, 84%, and not much of CMR. I know that this may not be truly reflective with the number of CMRs which are now coming up. And this is a 2018 study. So, but again, this is a comparison of how echo versus the other imaging modalities is very well established. Then advantages, disadvantages, it is non-invasive and no adverse events compared to the other modalities. When it comes to systolic and diastolic function, it is very accurate, especially with the newer imaging applications which are available. Analysis of valvular severity, accuracy, very good. And again, with strain and TDI, the sensitivity is much better in terms of interpreting. The inter and intra-observer always been held against echo, but now with better imaging tools, the probes, and then the better imaging quality which is available, and also with the availability of contrast, it has improved. And GLS also has been shown that it is very easily and widely and easily done when they have even looked at medical students, and they found that even within a day they can do it with a good amount of reliability. Now, when it comes to recommendations, again, based on data, so this is from the Journal of American Heart Association 2020, looking at the various agents, whether it is anthracycline, whether it is trastuzumab, you have echo right on top. So the various I'll not go through this slide, it's a very busy slide. But again, the message here is very simple, very easy to look, and very focused here. Echo recommended at every level. So the only time the MRI and the other imaging modalities are recommended are when technically it is not possible, or whether it is a high-risk patient and in some special situations. So with this, I rest my case. So I would like to say that cardiotoxicity assessment, echo imaging is always required. And that is something which is a very clear message. Thank you.
Dr. De.
Thank you very much, Dr. Govind, for an excellent presentation. Can we have a little discussion on it if there are any questions?
Unfortunately, we are running out of time. I would like to thank all the chairpersons and their esteemed speakers for their presence.